Good morning, everybody. Apologies for the delay in the starting of the class. Today we are going to see the third session on fetal echo, which is on Doppler assessment of fetal cardiac hemodynamics. So the first session we had seen the indications. The second we went through how to do a fetal echo, a practical approach. And the third is the Doppler assessment. The Doppler assessment will include the Dopplers of the fetus heart and also the peripheral Dopplers. Now we understand that the Doppler assessment is useful for what? It can help us confirming the normal flow and also displaying an abnormality in the flow, and also that it complements to the speed and the accuracy of the cardiac analysis, including the understanding of cardiac failure. And this is going to include the color Doppler and the pulse Doppler both. Remember that the pulse Doppler is accurately done by the curvilinear probe. However, for CW, we might have to use a cardiac probe. So what we are going to see in this short session is an overview of change in the fetal circulation, the color Doppler, its principles and structures seen, and the pulse Doppler, the rules, the different aspects, and at what all sites do we need to do a pulse Doppler during fetal echo. The most important is we understand that the fetal circulation is different than the postnatal circulation because the fetal circulation is a parallel circuit, whereas postnatally it is a series circuit in a normal heart. One of the most important difference is the right ventricular output being a little greater than the left. As we saw in the last class, normally the right heart is equal to the left heart or a shade more. That means the right ventricle is the dominant ventricle in the fetus. The right ventricular output is greater than the left. The second important understanding is that the fetus has a pulmonary vascular resistance and pulmonary arterial pressures, both of which being high. And the third is, as gestation proceeds, there is increase in the flow, which is primarily due to increase in the size of the valve orifice. As we know, the flow is equal to velocity into area, and we understand that velocity reasonably remains constant, whereas the size of the valve orifice increases, which causes the flow to increase, because of the change in the area. So what happens from 20 weeks to 40 weeks of gestation? What are the changes primarily happening? One is that the ventricular compliance changes as gestation proceeds. On the left heart, it changes more than the right heart. The change in the preload. The stroke volume hence changes by almost 10-fold by the time the baby gets delivered, and hence the combined cardiac output changes, and the pulmonary blood flow also to some extent increases. As we understand, the pulmonary blood flow is only 10% in early pregnancy, which comes to 25% by the time the baby gets delivered. However, the total peripheral resistance is not something which goes along with the above mentioned features. So the first is color Doppler. Now, where all do we use the color Doppler? So as we can see in this figure, the most turbulent structure which is seen below the diaphragm, as we saw in the last class, is the ductus venosus. So as we trace the inferior vena cava, we can see the ductus venosus Doppler below the diaphragm. So it's an example of how such a small vessel can be accurately identified using a color Doppler. The ductus venosus Doppler is useful for us even as early as in the 12 weeks scan, and if the ductus venosus Doppler is abnormal, it's an indication for doing a fetal echo, and it's an indication to suspect congenital anomalies, especially chromosomal anomalies. So it enables to identify small vessels like ductus venosus, which otherwise would be very difficult to visualize. The second important example is aortic stenosis. because we know that the pulse Doppler gradients may not accurately define the degree of stenosis. So in that situation, if you see a high velocity turbulent flow across the aortic valve, it reflects a possibility of aortic stenosis. And the third is if there is a flow in an abnormal direction. For example, mitral or tricuspid regurgitation, then it is an important evidence for certain things, like if it's more than mild tricuspid regurgitation, it could be an evidence of a genetic issue. If there is more than mild tricuspid and mitral regurgitation, it could be an evidence of impending cardiac failure. So color Doppler identifies such abnormal direction flow or even the presence of a ventricular septal defect where there is a flow which normally should not be there. So how do we do color Doppler? One is always follow a sequential segmental approach the way we saw in the last class. Second, select high velocity scales. And third, in general, try to use parallel flow in a vessel or a chamber to the direction of ultrasound beam so that you get more accurate results. So now the first thing we are going to see is what are the structures commonly seen in a normal heart on color Doppler. So this is the sagittal cut, and we are first seeing the systemic veins. So as we saw, this is a sagittal cut where the head is here and the legs are here, and we can see that this is the SVC IVC view. The SVC IVC view, when we go below the diaphragm, we can see this turbulent flow. You can see the flow is there throughout the cardiac cycle. It's so typical. Unlike the IVC flow or hepatic venous flow, this is present throughout the cardiac cycle on color Doppler, and this is the ductus venosus. It's in high velocity stream. As we can see in the first figure, the IVC and SVC are also seen. So the structures which are seen in the systemic venous drainage are the IVC, the SVC, the hepatic veins, and most important is ductus venosus. And what view do we use is the sagittal cut of the baby's sagittal section. The second important structure which we are seeing is the foramen oval. Now here we can see that the foramen oval is shunting from the right atrium to the left atrium. The right atrium is the atrium which is here and the left is here. And you can see a red flow across the foramen oval. The foramen oval is usually throughout the cardiac cycle, right to left, but an occasional left to right is possible. And what view do we use for flow of foramen oval is either the previous SVC IVC view or even a 4-chamber axial view can be used. Now all these color Dopplers we will recheck it when we go to the pulse Doppler also. The third structure is the pulmonary veins. Now pulmonary veins, we have to understand that all 4 veins sometimes may not be seen. However, as we understood in the last class, we have the ear-pulled appearance of the left atrium. As we can see, the descending aorta is here and the pulmonary veins enter the atrium below that. And we see this pulled ear sign on color Doppler. We trace the pulmonary veins entering into the left atrium, which practically rules out a total anomalous pulmonary venous connection and not a partial anomalous pulmonary venous connection. The next most important thing is the AV valves. As we can see here, we have a linear, smooth flow across the mitral and the tricuspid valves, and there is no regurgitation. The third is the interventricular septum, which is seen, and there is no color crossing across the septum. Remember, in a 4-chamber view, you might see a false dropout in the membranous septum, so it's very important to double check it in outflow views. There is no membranous defect. Here we can see the upper part of the interventricular septum, and there is no defect. The LV outflow tract is opened up and there is no defect. Remember, tricuspid regurgitation, mild quantity, grade 1 can be present in normal fetus. Now, these things are commonly seen in a 4-chamber view. Coming down to the outflow tract, we can see that the LV outflow tract is seen here. The left ventricular outflow tract is patent and there is no regurgitation. Similarly, the right ventricular outflow tract is seen in the second image where there is no regurgitation and there is a smooth flow. Also, simultaneously, we double check the LV outflow tract and the outflow tract, which tract is dominant, and as we see here, both the tracts are equally dominant. There is no regurgitation. Again, these views are taken in the 4-chamber outflow views. Outflow views in detail we will take in the subsequent classes, but it's important to make sure that there is a smooth flow with no turbulence and no regurgitation. The next two important structures are the aortic arch and the transverse arch. The aortic arch and the ductal arch. So we can see here in the first view, we have opened up the outflows again in the axial sagittal cut, where we can see the aortic arch and the ductal arch, where the flow is in smooth direction, same direction. The aortic arch is a smaller structure, more curver, and the ductal arch is more stouter. The ductal arch has more velocity than the aortic arch, but the flow is in the same view. This is again an extension of the SVC-IVC view. The second view, which shows from the 4-chamber a further sweep, and we can see the LV and the RV outflow tract, and then we can see the arches. As we saw in the last class, both the arches are on the left side forming a V, which makes it a left aortic arch. This is again something which we will see in detail in the 3-vessel view later. And then we see the right and the left pulmonary arteries from a short axis. So if we see carefully, this is the outflow view in the 4-chamber view, and we can still see the branch pulmonary arteries bifurcating. So we can see when the RV outflow tract opens up, the LPA and the RPA. The LPA is a structure which goes along with the ductal arch, and the RPA is on the other side. So we can see in the second figure, this is like a short axis, and we see here the LPA and the RPA. The LPA is going along with the ductal arch towards the descending aorta. The right pulmonary artery goes in the other direction towards the right side of the baby. So the branch PAs can be opened up either from the 4-chamber view when we sweep further, or we can see in the short axis view. Remember that the LPA is directed in a different direction than RPA, so all LPA, RPA and the duct may not be seen in the same view. Most commonly we open up the RPA and the ductal arch in one view, and then tilt a little more cranially, we get the LPA. Also see, this is the aortic arch. The aortic arch and the head and neck vessels can be beautifully seen on color Doppler, which helps defining a particular arch. So that's the important use of a color Doppler. And also that the distal aortic arch has a smooth flow. This is an indirect sign to rule out coarctation on color Doppler. Again, simultaneously, we can see a structure which is seen below the diaphragm, and this is what it is, the ductus venosus. Most of the times, the ductus venosus is seen simultaneously when you open up the aortic arch. So the color Doppler, what does it tell us? It shows patent connections throughout a normal heart and the flow in expected direction. It shows intact interventricular septum and an unrestricted foramen oval and ductus arteriosus, both of which are so important in fetal life. No turbulence at any point in the heart or in the main vessels. So this is the importance of color Doppler. Coming to the second understanding of pulse Doppler. Now what does the pulse Doppler do? Whenever the color Doppler is normal, it is not always important to pulse Doppler every single structure. But however, whenever you see an abnormal flow, you should Doppler the structure to document the velocity which is increased, normally with a pulse Doppler, but sometimes you may have a velocity which is more than what a pulse Doppler can take. Then you have to use a continuous wave Doppler. For that, you have to switch to a cardiac probe. Remember that the highest velocity which is present in a fetal heart is present in the ductus arteriosus, and the velocity is usually 1.6 meters, but it can go up to 2 meters per second. So with this understanding, we see how do we go about putting a Doppler sample. So for a pulse Doppler, you should place the sample volume distal to the respective valves. Distal in the sense, if it's a tricuspid or a mitral valve, you put it towards the ventricles, and if it's the aortic valve or the pulmonary valve, you put it into the great vessels. The insonating angle should be not more than 20 degrees. So as you understand, if I want to Doppler this and my cursor is going to be here, then remember that this angle is the insonating angle, should not be more than 20 degrees to be more accurate in terms of estimating the velocity. The third is you should place the sample volume at the brightest colors of the blood flow. So always use the color Doppler before you try to pulse Doppler. The Dopplers theoretically should be obtained in fetal apnea. So it's going to be very difficult for us to take that. So it's always important to take multiple measurements so that we do not have errors. So with this understanding, we now go to see what all sites we will see pulse Doppler. Now there are 4 aspects of pulse Doppler. One is it's going to tell us the direction of flow, which is going to confirm the color flow mapping. The second is it's going to tell us the velocity of the flow, and it's important for us to know what is the normal velocity at different sites. It's also going to tell us the pattern of flow. Pattern of flow in the sense in which direction it is going. And the last is it's going to tell us the volume, flow, and function, which we are going to see in a short detail at the end of the talk. So first of all, we go to ductus venosus. Now we know how to Doppler the ductus venosus. We put a color Doppler in the sagittal view. See below the diaphragm, the turbulent flow is the ductus venosus. And then we Doppler it. This is what we are going to get. Now ductus venosus has flow turbulent throughout the cardiac cycle. That means that it has flow throughout the cardiac cycle on the Doppler. And it also changes with respiration. So you will have a phasic tracing. As we can see very nicely in this figure, it changes with respiration, and it has typically the S and the D waves. The S wave is during the ventricular systole, the D wave is during the ventricular diastole, and then at the end of it you have the A wave, which is present, it still is there above the baseline. So it's a continuous flow even during this part of the cycle, which is the diastolic phase. So as we can see, the S wave, the D wave, and the A wave, but all are positive in ductus venosus. The S and the D ratio is important for us because it reduces as pregnancy advances. There's a peak in systole, there's a peak in diastole. Usually they are closer, same velocity, and there's a continuous flow throughout atrial contraction, or it's called atrial systole. So we have S, D, and atrial systole, continuous flow, and the velocity is still at this stage also up to 3 centimeters per second. Ductus venosus Doppler is very, very important because when it becomes abnormal, it can mean that as a pediatric cardiologist, we have cardiac failure, and it is not a good sign to pick up an abnormal ductus venosus Doppler. As we said, an abnormal Doppler early in gestation by 12-13 weeks can predict the possibility of a congenital heart disease or a genetic abnormality. So this is the S wave, this is the early diastole, and this is the atrial systole. Now coming down to the second important understanding is the pulmonary vein. Now in general, it's difficult to get pulmonary venous flow early in gestation, but as pregnancy proceeds, we understand that the pulmonary venous return becomes a shade better, up to 20% of the cardiac output, and in that situation, you might be able to get a nice Doppler tracing. So again, use a color Doppler in a 4-chamber view, and then put a pulse Doppler. What pulmonary venous Doppler reflects is the left atrial hemodynamics. It is not affected by respiration during pregnancy. So now we can see that we have a systole, we have again the diastolic wave, and then we have the atrial systole. So the systolic peak, systolic wave is there, and it's twice the volume of the diastole. The volume, it's not the velocity. The volume of the systole is much more than the diastole. So during the systole, we have a peak, and then we have a continuous flow, and then we have a peak in early diastole, and then we again have a very little flow during atrial systole, or almost no flow. The same thing you can see here. This is the systole wave, and then this is the continuation of the flow. This is the diastole, and almost no flow during the atrial systole. We might have a reversal of the A wave in case there is a problem with the left atrial pressure. That is something we will see later. Now the foramen oval Doppler, as we understand, it's predominantly from the right atrium to the left atrium. So here we can see the right atrium to the left atrium flow dominantly throughout the cardiac cycle. So throughout the cardiac cycle, it's from the right to the left, peaking during systole, another peak during the diastole, and almost no flow during the atrial contraction. So it touches the baseline during atrial contraction. A transient left to right flow may be there very transiently. So as we can see here in this figure, this is the right atrium, this is the left atrium. So what we are seeing above the baseline, the S and the D wave, and a transient left to right peak. This is going to be abnormal if the flow starts becoming predominantly from left to right in cases where you have development of hypoplastic left heart, etc. Or by any reason if the LA pressures are more than the RA pressures. Coming down to the AV valve Dopplers. Now, as we understand the way we see the AV valve Dopplers in postnatal life, in a similar way we have E and A waves, the two waves as we see. The E wave is the passive filling from the LA to the LV, and the A wave is the atrial contraction contributing, which is producing the A wave. But in contrast to postnatal life, typically the E wave velocity is lesser than the A wave, giving a ratio of almost 0.5 during early pregnancy, which becomes closer to 1 by the time the baby gets delivered. So this is important. The E wave velocity lesser than the A wave velocity, and then the E wave velocity is something which increases during pregnancy. The A wave remains constant. E wave velocity increases, and then the EA ratio becomes closer to 1. As we can see here in the Doppler, the E and the A across the mitral valve flow is only during diastole, no flow during systole. Sometimes you may have a merging of E and A wave. Now, it may be just physiological, but whenever you have pathological problems, also a uniphasic pattern can be seen. The tricuspid velocity is similar to mitral, except the velocity is a shade higher because RV is the dominant ventricle. Otherwise, it's going to be EA ratio of 0.5 approaching 1 by the time the baby gets delivered. Remember that the mitral and the tricuspid valve Dopplers, what do they reflect? They reflect the ventricular compliance during pregnancy. The compliance becomes better at the time of birth, and the Dopplers change. The shift from the right to the left heart dominant also happens during late gestation, and then it becomes more matured by the time the baby gets delivered. Coming to the aortic and the pulmonary valve Dopplers. So as we understand, like postnatal life, we have flow, single flow during cardiac systole, and then no flow during cardiac diastole. And what it reflects is that it reflects a combination of the ventricular contractility, the arterial pressures, and the afterload. What are the parameters we can see in the Dopplers? One is the acceleration time. The acceleration time is from the beginning of the Doppler to the peak is the acceleration time. And second is the velocity time integral. How do you get the velocity time integral? You just have to trace the whole tracing of the aortic valve and you get a velocity time integral. It practically means, the mean velocity into the time duration taken. So the peak velocity is usually greater than aorta in aorta compared to the pulmonary artery because the afterload of the aorta is lesser compared to the pulmonary artery. The acceleration time is longer in aorta than the pulmonary artery because the resistance faced in the LV is slightly lesser. So these are the things to be seen in the aortic and the pulmonary valves. The arterial duct, we remember that the ductal arch velocity is maximum in fetal life. Normal heart, maximum velocity is seen in the ductal arch, and typically the flow is like this. It happens during systole, but during diastole, you still have a forward flow. So typically we can see here, we have this, the peak is there during systole, and then we have another peak during diastole. So this is a very different Doppler pattern compared to other vessels. Remember that the ductus arteriosus is a conduit between the aorta and the PA in fetal life. So it is a little different structure compared to other vessels. The peak velocity is reflecting the difference between the aorta and the PA. This forward flow in diastole has to be there. Occasionally, a transient short reversal of flow is also possible. So this is the peak systole and a peak diastole, but a continuous flow during diastole. The branch pulmonary arteries also has a very peculiar pattern. We do not see this type of a Doppler pattern anywhere postnatally. So we can see here a typical sharp peak during systole, then we have a slow decline, and then we have a continuous plateau in diastole, a forward flow in diastole. This typical characteristic pulmonary arterial flow is because of increased pulmonary vascular resistance and low capacitance, which is peculiar of a fetal pulmonary vascular bed. So the sharp peak, slow decline, a forward flow, and sometimes a transient reversal of flow can be seen because of pulmonary valve closure, which can happen. Remember that the systole velocity more and the diastolic flow is less as we approach the origins compared to the distal field. So this is how a peculiar pulmonary arterial flow happens. The aortic isthmus, we have a typical flow, arterial flow during systole and a low-grade flow during diastole. Now coming down to how to calculate the volume across an aortic, across the fetal heart. So what we can see here is inflow-outflow Doppler. So it's a mitral inflow and the aortic outflow. You put a pulse wave Doppler there. What we are going to get is the mitral inflow and an aortic outflow. So this is where we are going to measure the ejection time, flow across the aortic valve, and the IV-RT, IV-CT, the isovolumic relaxation and contraction time. And based on that, we get the myocardial performance index. This is supposedly a load-independent index for myocardial function, which actually is true for both the ventricles, but it's difficult to get on the right side. So in summary, the pulse Doppler gives us huge amount of information, and as we can see here, we Doppler the AV valves, the seminal valves, the venous structures, the pulmonary veins, the systemic veins, the ductus venosus, the PFO, the ductus arteriosus, and the branch pulmonary arteries. So what is it going to give us is the compliance, the ventricular compliance and the diastolic functions known from the AV valves, the ventricular contractility, the afterload and the arterial pressures from the seminal valves, the atrial hemodynamics based on the ductus venosus and the PFO Dopplers, the pressure gradient between the arterial circuit, or even a premature ductal closure based on the ductus arteriosus Doppler, and peripheral pulmonary vascular resistance and capacitance based on the branch PS, and at the end of it we get volume, flows and functions. Thank you so much for your patient listening. Any questions, feel free to ask.